Okay, very good. So it's welcome, everybody. Thank you so much for joining us for today's webinar. We're going to discuss the importance of coordinated care in addressing VHL. By the way of introduction, I'm Dr. Janie Chen. I'm one of the assistant professors at UT Southwestern. I see our genital urinary cancer patients. I also run a VHL clinic where I see a lot of our VHL syndrome patients. Joining me is Dr. Kevin Courtney, who's the professor of internal medicine and the director of our genital urinary medical oncology division. Dr. Courtney is our sponsoring physician for UT Southwestern VHL, and also sees some of our VHL patients. And then we also have Brian Reyes, who oversees our genetic counselor department, who may be joining us today. So with that, we will get started with first some housekeeping, which is we will kind of go over what is VHL. We'll have a session for question and answers, but do keep in mind for the Q&A, we will be answering general VHL related questions. If you have very specific, questions about a specific patient case, those will be better discussed with the physician treating the patient. All right, so what is VHL? It's a rare inherited tumor predisposing syndrome caused by a mutation in the VHL gene. It affects about 1 in 36,000 patients, including about 10,000 people in the United States. It can cause tumors and cysts in multiple organs. Then in about 20% of the case, it's de novo or first in family. So let's first understand kind of the cause of VHL syndrome. And so what drives the signs and symptoms we think is due to a mutation in the VHL gene. And so our body has ways of dealing with low oxygen. And so in normal oxygen state, we have a protein called HEF-alpha. It actually gets degraded by a PVHL-mediated pathway, and it does not combine with HEF-beta and does not cause upregulation of downstream genes. However, in low oxygen state, our body wants to make more blood vessels and grow and upgrade, regulate genes that helps to deliver more oxygen. So in this case, HEF-alpha is not degraded, then it is allowed to combine with HEF-beta, and the combination leads to upregulation of genes downstream that promotes things like increased blood vessel formation, cell growth, etc. And so in VHL syndrome, because there's a loss of the VHL gene, the HEF-alpha is not degraded even in normal oxygen. And so there's an abnormal upregulation of this pathway, which then leads to abnormal formation of, vasculatures, cell growth, etc., that we think cause these cysts and tumors to develop in VHL syndrome. So what are these potential disease manifestations? So going from top down, within the CNS, which is the brain and the spinal cord, patients can develop hemangioblastomas. They tend to occur in the cerebellum, which is kind of the lower back of the brain that helps us with balance, as well as the spinal cord. And then in the eyes, retinal hemangioblastoma can occur, and these can, of course, lead to issues with sight. And then in the kind of middle inner ear, endolymphatic sac tumors can develop, which can affect our hearing, cause ringing in the ear, symptoms associated with that growth. And then moving down in the adrenal glands, which are these small organs that sits atop of the kidneys and make certain hormones our body needs. A type of tumor called pheochromocytoma can develop, and sometimes these pheochromocytoma tumors can secrete kind of adrenaline hormones. And so one can imagine if adrenaline hormones are secreted randomly in spurts, that can cause things like increased heart rate, headaches, high blood pressure, things like that that can be difficult to control. And then below the adrenal glands are the kidneys. Both cysts and kidney tumors called clear cell renal cell carcinoma can develop within one or both of the kidneys. And then in the middle is the pancreas, and here cysts or a collection of cysts or a type of pancreatic tumor called pancreatic neuroendocrine tumor can develop. Finally, in the broad ligament of female and the epididymis of male, we can see cystadenomas as well. So what are our treatment options for VHL syndrome-associated tumors? So for locally directed therapy, we have the options of surgery, so resection of the tumor. We can do radiation, or we can do laser or freezing, which is also called cryotherapy. In terms of systemic therapy, which is any medication that we take by mouth and get as injection or an infusion that travels all throughout the body and tries to control the tumor anywhere it may be, that would be any medications. And so I did want to focus on this medication portion in the form of Belzutifan. And so this group may already be well aware of Belzutifan. It's a HEF2 alpha inhibitor. So if we think back on the figure we just looked at of HEF alpha combining with HEF beta to cause downstream effects, wouldn't it be nice if we can prevent HEF alpha from binding to HEF beta and thereby stopping the pathway that causes the increase in vasculature, cell growth, and thus the cyst and tumor development. So that's where Belzutifan came in. It's actually a drug that was developed here at UT Southwestern. And this is the LifeSpark 004 clinical trial. And so on this trial, VHL syndrome patients with kidney tumor and any other, VHL-associated tumors were enrolled and treated with Belzutifan 120 milligrams once a day. The investigators wanted to see how well Belzutifan can shrink the kidney tumor as well as other VHL disease-associated tumors. What I want to highlight here is that there was a really great response to Belzutifan in terms of the different different tumor types like kidney tumor, CNS hemangioblastoma, and pancreatic neuroendocrine tumor. And so what this is, it's called a waterfall plot. And so any bar that goes above 0 means that the tumor has grown. Any bar that goes below 0 means that the tumor has shrunk. And so as we can see here, almost all of the tumor lesions did shrink with Belzutifan use. And if it shrink a lot, more than 30%, that's considered a partial response. So those would be more or less your purple bar. And then if the tumor completely went away, then that's called complete response. And those will be shown in the green bars. And so we can see that there's really great response to Belzutifan of these VHL syndrome-associated tumors. And based on this, the FDA approved Belzutifan for VHL syndrome patients with kidney, pancreatic, and/or CNS tumors in August of 2021. The other thing I really wanted to highlight is the number of procedures. And so these will be surgeries, radiation, laser, freezing, any locally directed procedures to treat the VHL-associated tumors. And so what we see here in gray are, patients before they started Belzutifan, and all the dots that we see are the procedures that patient underwent. So we can see most patients have multiple procedures within 5 years leading up to starting Belzutifan. And then the bars in green are when patients are on treatment with Belzutifan. And really, we see a very significant decrease in the number of procedures because of Belzutifan initiation. And so I think the goal and the role of Belzutifan is to decrease the tumors of interest and to prevent procedures, which certainly comes with its own set of side effects. So with that, let's jump into what is coordinated care. And so in VHL syndrome, as we've seen, patients can have many organ involvement. And so a single primary doctor is often not enough. Most of the times, these patients need a multidisciplinary team of specialists like neurosurgeons, urologists, eye doctors, endocrinologists, genetic counselors, and us as medical oncologists for their care. And a coordinated care is one that's seamless, holistic, and timely communication between all members of the healthcare team, including the patient. What are the challenges of uncoordinated care? It can cause delayed diagnosis and treatment, missing early small lesions due to isolated screening. It can lead to conflicting advice when different specialists recommend different courses of action without consulting each other. And these can certainly cause patient burden and burnout, where patients are managing multiple appointments, records, and communications across different institutions. And these would increase the risk of complications, disease progression, and potentially unnecessary procedures if surveillance is not synchronized. An example would be if a kidney tumor was growing while a patient's focused on recovering from a spine surgery with no one tracking the kidney lesion. And so what are the benefits of coordinated multidisciplinary approach? It allows for a holistic patient view where we're treating the patient with VHL, not just the isolated tumors. It allows optimal surveillance with adherence to VHL Alliance active surveillance guideline for early detection. And then when tumors are detected, it allows for timely intervention where specialists are consulted to determine the best time for surgery or systemic therapy to prevent severe complications. And finally, improves quality of life by reducing stress for patients and caregivers with better management of long-term and secondary effects like pain and anxiety, and allows for efficiency when there's centralized medical records and a clear point of contact. What are some strategies for achieving patient care coordination? We have many strategies, including the VHL Clinical Care Network. And so VHL Alliance has recognized certain clinical care centers, which are institutions dedicated to a coordinated multidisciplinary team approach. And so looking for clinical care centers will certainly help in terms of getting all the experts under one roof. There is also the VHL Handbook, which is a tool for patients and doctors to understand the disease and surveillance protocols. There are VHL surveillance guidelines that provide a roadmap for what scans and tests are needed and when. And the importance of self-empowerment, where these empowers the individual to be the owner of their own care. Additionally, we do have VHL specialist and navigator. There is often a designated physician or nurse navigator at one of these clinical care centers who can keep the big picture and track the surveillances. It is important to have centralized records, maybe a binder or digital file of scans, reports, and genetic test results. There are strategies to facilitate clear communication between perhaps the local doctors and their VHL specialists. One option would be asking the reports to be sent directly to the local doctor from the VHL specialist. And finally, genetic counseling, which ensures that all at-risk family members are well informed regarding genetic testing and counseling. And so, where do we feel like the future of VHL care coordination should be? It should incorporate new systemic therapies like Belzutifan into the patient's treatment plan when needed. There is a role of telemedicine and technology to bridge geographic gaps between patients and VHL experts. And certainly there's importance of patient registries like My VHL in research that informs care standards. So key takeaways, VHL is a complex multi-system disease. Coordinated multidisciplinary care is not a luxury, but a necessity for the best outcomes. And the VHL Alliance is here to provide the resources and connections needed. And of course, we as physicians are here to help with the treatment of VHL syndrome-associated tumors. Thank you very much. With that, we're actually going to open the floor for any questions.
There's a question in the chat here. Can you comment more on telemedicine, uh, in particular for people in states without CCCs?
Yes, thank you. So, thank you to everybody for joining and uh, Dr. Chin's outstanding presentation, and thank you to Josh for preparing and organizing all this. One of the challenges we face with telemedicine, and this will need some evolution over time, is how to carry out telemedicine when you are out of state. Currently, as physicians, our licenses sort of stop at the border of our state. We're licensed to practice state by state. But there are options emerging to try to provide some coordinated care and guidance. And there are VHL Alliance affiliated tumor boards, for example, where providers in states, providers who are seeing VHL patients, but are not part of a VHL clinical care center, can provide case presentations to those tumor boards that are organized by the VHL Alliance and attended by providers from various VHL clinical care centers who can offer some guidance in those circumstances to try to help coordinate the care you need closer to home. There's another question in the chat that notes in your presentation, it says coordinated multidisciplinary care is not a luxury, but a necessity for the best outcomes. I agree. How can we make that clear to folks in charge of hiring spending at our clinical care center? So, I mean, this is where group advocacy comes in and is very important. This is where having the power of the community and the VHL Alliance can come into play in trying to advocate for more information and more coordinated care at VHL for patients with VHL who don't have ready access to a VHL clinical care center or who have a VHL clinical care center where there's turnover and in terms of providers who provide that coordinated care.
Thank you, Dr. Courtney. It looks like there's a question about closest clinical care center to Northeast Mississippi. I think that one maybe we'll have Josh answer. And then there is a general question regarding Belzutifan. Is there a time frame for how long it can be taken, or is it currently thought to be taken indefinitely? It's a really excellent question of how long, patients should take Belzutifan, especially since the drug has been approved for a couple years. And, we do have some younger patients who are starting to take Belzutifan. Right now, we don't have specific data on the length of how long to take Belzutifan. And so the short answer is it is continued as long as it's working and patients are tolerating. That being said, it's on a patient-to-patient basis, whether patients should take a treatment holiday from Belzutifan and how long that treatment holiday may be. We don't have much data to guide us, but we can certainly clinically, right, kind of set up interval scans to monitor the tumors closely and work out a plan for potential treatment holidays.
And to follow on Dr. Chin's points, one of the things that we're learning through further research is, how do people do long term with Belzutifan? To that end, there's actually, a clinical trial that's exploring this. At our site, Dr. Chin's going to be leading that trial, where patients who are receiving Belzutifan as standard of care, if they participate in that trial, you can provide updates to sort of a central registry to gather that information in terms of longer term side effects and quality of life issues.
Looks like there's another question about the link between you mentioned the hypoxia linked to VHL tumor growth. Is there any understanding of how, if sleep apnea is linked to tumor growth? Um, Not that I'm aware of. I don't know if Dr. Courtney, you're aware of any data regarding sleep apnea and tumor growth.
No, not aware. And just to clarify, and it's a very good question to bring up, just to clarify the mechanism that we're referring to when we refer to hypoxia and it's linked to VHL. It's not so much that hypoxia itself is linked to tumor growth. It's that under normal circumstances, the way that the VHL protein regulates this transcription factor that is the target of Belzutifan, which is HIF2 alpha, is to sort of downregulate it when there's plenty of oxygen around. So to basically, you see that there's plenty of oxygen around. That oxygen can sort of tag the HIF2 protein through with a process called hydroxylation. And when that HIF2 protein becomes hydroxylated, the VHL protein can recognize it and sort of steer it to be destroyed, degraded. However, under situations where when you need oxygen, you want that HIF2 protein to be there. So when VHL is altered or lost, as is the case in patients who are dealing with VHL syndrome, you don't have that normal down regulation of HIF2 alpha protein. And so it can be sort of on all the time in a sense.
Great. There's another question of can Belzutifan be safely started for a patient who can't do regular monitoring in the US and has no VHL center locally? It's an excellent question. Uh, Belzutifan, although it's quite a well-tolerated drug, it really does need to be monitored. Particularly, it can cause things like anemia, which is low red blood cell count in patients. Almost in all patients who start Belzutifan will have lowering of their red blood cell. And so we do need to look at blood count and make sure it has not dropped to a dangerously low level. Other things are, liver function, for example. In a very small cohort of patients, it can cause liver enzyme elevation. And so we certainly want to keep a close eye on the liver. Very, very uncommon, but dangerously, Belzutifan can cause low oxygenation, what we call hypoxia. If that occurs, the patient really needs some more urgent intervention to bring up the oxygen, stop the Belzutifan, and potentially start at a lower dose. Although it's a great drug, it's very easy to tolerate. It is not without side effects. I do recommend any patient who starts Belzutifan should get regular monitoring intervals with their physician.
There's a question in the chat regarding tips navigating insurance. That's something as physicians we're not the best versed at. But what we can say is, the challenges that patients face when they're in a state without a clinical care center for VHL, one of the things that we have learned, for example, is, Dr. Chin and I, are medical oncologists, and we came to our interest in VHL and tumor biology as genitourinary cancer specialists. So we focus on treating patients with kidney cancers, among others. And so there is a growing understanding of Belzutifan and its use among oncologists in the community. And so there are opportunities there to have discussions with oncologists in the community who can then be able, as we discussed, to bring to the fore to bear resources like through the VHL Alliance to try to help them in navigating these processes and following sort of surveillance guidelines that are provided by the VHL Alliance.
Great. There's a question about this hyperbaric oxygen therapy help in VHL. Again, excellent question. Similar to what Dr. Courtney has just explained with the prior question. With VHL syndrome, it's not so much a lack of oxygen, but a mutation in the VHL gene that causes even in normal oxygen, HEF alpha is not degraded and it binds with HEF beta. Hyperbaric oxygen therapy will probably not help because in this case, it's really not oxygen dependent. Okay. It looks like we have someone who said NCI is also clinical care center, could be worth looking into care from them. That's an excellent point. Thank you. And Josh put in the chat his contact information so that if anybody is looking for help finding care, feel free to reach out to Josh at VHL Alliance.
There was a question about if there was evidence that tumor growth accelerates after Belzutifan is discontinued. Also, a very good question. And so, when we start patients on treatment with Belzutifan, they're being monitored for tumor growth while on the course of treatment. If they need to take a break from treatment for toxicity reasons, side effect reasons, or life event reasons, then we would continue to monitor that. We don't have available evidence currently that tumors grow, for example, faster if you withdraw Belzutifan than if you had never been treated with Belzutifan. But when you remove the treatment over time, tumors that have stabilized or have decreased in size do have the potential to grow. And, we are learning as more patients are being treated with Belzutifan, what subsequent retreatment response rates look like and disease stabilization looks like.
Looks like there's a question about is there a suggested monitoring protocol for Belzutifan treatment holidays? It's a fantastic question. I don't think there is a set one because we don't have much data in this space. So I think it is very patient to patient dependent and treating physician dependent as well. And so the best approach would be to have a discussion with your treating physician. If you are interested in a Belzutifan treatment holiday, what does that look like, right? It might look like getting scans at intervals, right? A few months, maybe longer, to make sure that the tumors are not growing. It might be still getting interval labs to make sure that, the red blood cell count is coming up, etc. And so, because we don't have data to guide us, we don't have a specific set protocol. And so, really, it's a discussion with your treating physician. We have another question that says, what is the criteria to start Belzutifan? Fantastic question. And so on the trial that I presented, all the patients that enrolled, there were 61 patients, had kidney tumor. And then they can have additional any other tumor types, CNS hemangioblastoma, retinal hemangioblastoma, pancreatic neuroendocrine tumors, etc. And so, because on the trial, the treatment with belzutifan led to significant shrinkage of the kidney tumor, any patients with clear cell renal cell carcinoma kidney tumor that's localized and smaller than 3 centimeters would fit the criteria to start belzutifan. 3 centimeters because above 3 centimeters, there's a potentially higher risk of the tumor growing and metastasizing. So we may have to think about surgical resection, but certainly below 3 centimeters is appropriate for starting belzutifan to hopefully shrink the tumor and avoid surgery. In addition, on the trial, there was enough patients with CNS hemangioblastoma and pancreatic neuroendocrine tumor for us to see the effect of belzutifan on these tumor types. And there was also significant shrinkage of these tumors. And so based on that, any patient with CNS hemangioblastoma who does not need urgent surgical intervention and has pancreatic neuroendocrine tumor, again, without a need for surgical intervention, is also appropriate for initiation of belzutifan.
There's also a question, is there a place where we can read about potential other belzutifan-related symptoms to watch for? Yes, so there are resources for patient literature available online regarding belzutifan. There are resources from the sponsor that produces belzutifan, but there are also resources available through the VHL Alliance and through the National Cancer Institute that can sort of describe some of the potential side effects and things to watch out for that might be signs or symptoms of VHL treatment with belzutifan-related toxicity.
Very good. If there's any additional questions, of course, we're here and we're happy to answer. Us at UT Southwestern and any of the clinical care centers would, of course, be happy to help coordinate your care. We really want to be a partner with you in terms of your treatment and your VHL journey. Thank you so much, everybody, for joining the webinar.
Thank you again. And Josh, did you have any additional comments in closing or information for our audience?
Just thank you to Dr. Courtney, thank you to Dr. Chin, and if anybody ever needs anything, or has any questions about where they can get care or resources, you could always give me a buzz, josh.mann, M-A-N-N, at vhl.org, or you can go to our website, vhl.org, or you can connect with us on the Facebook page. But however you want to connect with us, we're always here and available and happy to point you in the right direction and arm you with the latest information. So thank you so much for joining us. And again, Dr. Courtney and Dr. Chin, thank you so much for leading a wonderful session.
Of course. Thank you, everybody.
Take care, everyone.